my pleasure and privilege to introduce today's speaker in the Royal College webinar series titled An Introduction to Bariatric Surgery. As you all know, the Royal College of Surgeons of Edinburgh have been running this webinar series since March and has proved to be quite popular among medical students as a hugely useful resource for common surgical problems. So Ms. Cynthia Borg, who is going to give you a talk on bariatric metabolic surgery, qualified from the University of Malta in 1997 and went on to complete her MD from the University of London, focusing on changes in gut hormones after bariatric surgery. Ms. Borg completed her specialist surgical training in upper GI and bariatric surgery in London and Northeast Thames region, and completed a laparoscopic and bariatric surgical fellowship at the University College Hospital, London in 2012. Cynthia was appointed as a lead consultant surgeon at the University Hospital, Lewisham. Her specialist clinical and research interests are bariatric and metabolic surgery, besides laparoscopic abdominal surgery, including gallstone disease and gastroesophageal reflux. Ms. Borg has published extensively in peer-reviewed journals, is a reviewer for several international journals, and has presented in various national and international meetings. She is a regional surgical advisor of the Royal College of Surgeons of Edinburgh. Cynthia is also an elected council member of the British Obesity and Metabolic Surgical Society and of the Association of Upper GI Surgery of Great Britain and Ireland. Without much further ado, I invite Ms. Borg to deliver this webinar on bariatric surgery for obesity, which I'm sure you all will agree is a forgotten pandemic and a hot topic in the midst of the current raging COVID pandemic. Cynthia, the floor is all yours.
Thank you very much, Vital. Welcome to all of you. So today we're going to talk about metabolic and bariatric surgery. This is what we're going to talk about today. When we're talking about the operations, I'm not going to dwell a lot on the complications, as Vital and I are giving another webinar in September about the same topic. So, the history of obesity in humans is indelibly related to the history of food acquisition. Throughout human history, chronic malnutrition of the masses was the norm, and that persisted well into the first half of the 20th century, certainly till after World War II. Natural selection rewarded those with the so-called thrifty gene, those who could store the greatest amount of fat from the least amount of the then erratically available foods, and those that could release the energy as frugally as possible over the long run. This ability to store surplus fat made the difference between life and death, not only to the individual, but also, more importantly, for the species. However, as far back as 400 BC, Hippocrates recognized that those who are constitutionally very fat are more apt to die quickly than those who are thin. Worldwide obesity rates have nearly trebled since 1975. And in 1997, the WHO, together with the International Obesity Task Force, published this very important report. In this report, they said that obesity is a disease. It is complex, serious, and chronic. It required not only prevention strategies, but also management at both the individual and societal levels. Obesity is defined as the disease in which excess body fat has accumulated to such an extent that health of the individual may be severely affected. Now, as you know, it's very difficult to measure exact body fat ratios and content outside a lab in real life. So we have a surrogate, and that surrogate is the BMI. So BMI is the weight in kilos divided by the height in meters squared. And that is the BMI ranges. So when we're talking about obesity, we're talking about patients whose BMI is more or equal to 30. And when we talk about individuals suffering from morbid obesity, we're talking about class 3 obesity, that is, those with a BMI of 40 or more. The WHO estimated that more than half the adult global population is either overweight or living with obesity in 2016. In the UK, that has been estimated to be over 60%. And that is not taking in context the severe pandemic of childhood obesity. Now, why do we treat obesity? We treat obesity because it affects our patients' lives. They certainly have decreased quality of life. Their obesity may predispose them to socioeconomic as well as psychosocial problems. They certainly have a reduced life expectancy. And as you probably have seen in multiple clinics that you've attended, it affects most organ systems. So if you've attended the psychiatry clinics, you may have met patients with eating disorders, poor image, poor self-esteem and body image, depression secondary to their weight. Certainly in chest clinics, you see patients suffering from obstructive sleep apnea as a result of being overweight, as well as OHA. In upper GI clinics, certainly it's one of the causes of reflux and certainly a cause of NASH, and it is currently the commonest cause of cirrhosis. And again, we've got the cardiovascular problems, hypertension, ischemic heart disease, as well as the endocrine problems. And we know that obesity is actually driving the type 2 diabetes pandemic. In 2015, the IDF estimated that 1 in 11 adults has type 2 diabetes. The global expenditure pre-COVID was about 12% of the global health expenditure. And every 6 seconds, one person dies from diabetes-related disorders. Like obesity, diabetes is a multi-system disease with micro and macrovascular complications. We know that prevention is better than cure in both obesity and diabetes, and certainly a healthy lifestyle is what is advocated by most governmental policies. However, that usually doesn't take into account patients who already have the disease, and we need to think about them and to come up with effective treatment to at least get them into remission or to help them in their chronic illness. We know that 10% weight loss has great benefits, not only in terms of the diabetes profile, the lipid profile, the hypertension, but it also decreases early mortality. Now, with regards to management, you know that there are non-surgical options, and these are fine for a small amount of small percentage of the population. These can include things like diets, exercise, behavioral modification. They also can include drugs. And in the UK, currently we only have one drug that is licensed for obesity, which is Orlistat. We also have some endoscopic techniques which can help our patients, like the gastric balloon, which is like a space-occupying balloon in the stomach. The problem with these non-surgical treatments is recidivism, meaning that we often see patients in our clinics that have been yo-yoing up and down all their life. When they're on a diet, they manage to lose weight. Once they're off the diet, they gain the weight. And sometimes, because of the changes in gut hormones and in neural pathways, they not only gain the weight, but also gain a little bit more, as that their hypothalamus tries to protect them against further episodes of starvation, what their body thinks as starvation from all those years that we said those thrifty genes have evolved. Bariatric surgery is currently the most effective treatment and the most long-lasting treatment for patients with severe obesity, not only clinically in terms of the response to weight and comorbidity resolution, but also in terms of cost. Now, is bariatric surgery for everyone? Certainly not. Yeah. So, NICE have come up with some guidelines for us, and these were reviewed a few years back as well. So, the bariatric surgery is recommended for patients who have a BMI of 40 or more, or those who have a BMI of over 35 but have significant comorbidities. The significant comorbidities can be things like diabetes, sleep apnea, hypertension, ischemic heart disease. Patients are usually 18 or over. It doesn't mean that in a very few centers that this is not offered to teenagers, but it is only to very few in a few centers, and certainly after lots and lots of input with the MDT, not only as regards to the patient himself or herself, but also with regards to the family. There should be no specific clinical or psychological contraindications to surgery. The operations entail a general anesthetic, so the patients need to be fit for GA. There needs to be multidisciplinary input, whether an adult or an adolescent, and they should have tried appropriate and available non-surgical measures. Yeah. So in the UK, they should have gone through what we call a tier 3 service. A tier 3 service is like a medical service where if there are any medical problems, they're ameliorated, where the patients have dietetic input, psychological input, exercise input, if required. And the patients need to understand that this is not a quick fix, but if they have surgery, they need long-term follow-up, which we will discuss a little bit later on. What these guidelines also show that there needs to be an expedited assessment for patients with recent onset type 2 diabetes if they've got a BMI of 30 or more. And for Asian patients, we can go at least 1 or 2 BMI points less than that BMI of 30, because we know that in Asians we get complications of diabetes and obesity at a much lower BMI. And again, they would have to have gone through the tier 3 service or equivalent. So again, surgery is a multidisciplinary approach. The operation is only one small step. They need to have pre-op dietary education and in some modification, psychological support, medical and nutritional screening, and medical amelioration. And the bariatric unit, needs to provide long-term support. Now in the UK, most units are paid by the CCGs for a 2-year follow-up, but most have an open door policy that if anything else happens during the patient journey, be it 2 years down the line, be it 5 years, 10 years down the line, have an open door policy to see their own patients. Now, in terms of surgical management, it can sometimes be quite confusing when you see the different operations. There are some, like these two, the JIB and the VBG, that are historical. It means that we don't do them anymore, although there still can be some patients running around with those operations and that may present to you with either for something else or due to long chronic complications from these operations. There are other operations that are here, the BPD, and that are malabsorptive. They are not They are not performed much in the UK, and I'm not going to be discussing them today. So what I'm going to be discussing is these four operations here. This is the gastric band, the sleeve gastrectomy, the Roux-en-Y gastric bypass, and the single anastomosis gastric bypass. So this is gastric banding. Imagine a silicone ring around the upper part of the stomach. The ring, inside the ring, there is like a balloon that can be inflated or deflated via this port, which is under the skin. Yeah. So if you inject saline into it, you can make the tightness of the band around the stomach more. If you take fluid out, it will ease the pressure and ease the restriction. Now, gastric banding was very, very popular about 10, 15 years ago. It is associated with a very low early morbidity and mortality. The early complications are just similar to laparoscopy, like iatrogenic injury, or possibly port side bleeds. And then most patients would not need any mineral or vitamin supplementation, although nationally we would usually suggest that they have a multivitamin. However, it does need multiple adjustments till you get that balance of the tightness right. It's called getting into the green zone. Some patients do not lose weight with the band, and some patients may develop complications. And those complications may lead, or the not having weight loss may lead to about 20% removal long-term of these bands. The complications can include erosions, which is like this. So the band that's placed on the serosal surface cuts through into the stomach, like cheese wires into the stomach. So in this position, it will not give you any restriction at all. So the patient usually comes to you and says, my band was working fine, but now I can't feel that, I can't feel any different from pre-op. And the other telltale presentation of this is getting an infection in the port site, which is the system is usually sterile if it's outside the stomach, but then if it cheese wires and gets into the stomach, it may present with an infection that treks all the way to the port from the stomach. Sometimes we get this if the band is too tight. We get patients coming with regurgitation because they've got a dilated pouch and megaesophagus. And sometimes we get this, which is slippage of the band, which what happens is that the distal part of the stomach herniates through the band. And the problem with that is ischemia. So if you ever encounter a patient who is vomiting or dysphagic after band, that is a surgical emergency. The patient needs to see a surgeon as soon as possible. Yeah, if the surgeon doesn't, it may need to be escalated to an upper GI or bariatric surgeon. Now, the next operation, which is currently the most popular operation, the most done worldwide, is this, the sleeve gastrectomy, where we laparoscopically mobilize the greater curve. Then the anesthetist passes a tube called a bougie from the mouth down to the stomach, and we use it to calibrate how much stomach we leave in situ, and the rest we remove. It is a good operation because there's no artificial material. Once you've done it, you've done it. There's no need of repeated adjustments. It's not affected by adhesions or small bowel pathology. And like the bypass, it results in rapid weight loss and a change in gut hormone profile. And what the gut hormone profile is, it makes the patients feel more full, more satiated easily, and less hungry. Contraindications include problems with reflux, things like Barrett's, symptomatic GERD, and large hiatal hernias. Once you've done it, it's irreversible. Once that greater curvature is gone, that fundus is gone, it's gone. You can't change it back. And complications can include leaks. Because it's a high-pressure system, leaks can be quite a problem to deal with and may result in fistula formation. It also, because it's a tube, sometimes it can twist on itself, or else if there is some problem in drop resulting in the posterior side being shorter or longer than the anterior side, it may twist for you, causing functional obstruction. And again, one of these complications itself could be worsening of reflux or de novo reflux, as well as complications of reflux like esophagitis, strictures, and Barrett's. This is the Roux-en-Y gastric bypass. So what we do in the Roux-en-Y is create a small gastric pouch, and then we measure the small bowel starting from DJ. So we measure this, that's called the biliopancreatic limb. Most people would do that about 80 to 100 centimeters. Then cut the small bowel there. The bit that was distal goes up there. It's called the alimentary limb. And then it's joined to the biliopancreatic limb there to form this, which is the common channel. So food would go through the small pouch into the alimentary limb and starts mixing with the enzymes from the stomach, from the pancreas, and the bile, starts mixing at this point there in the common channel. So the biggest part of the stomach, the duodenum, as well as a segment of the small bowel, is bypassed. That's why it's called a bypass. Again, like the sleeve, no artificial material. Once it's done, and it changes the gut hormone profile similar to what the sleeve does. Contraindications include small bowel pathology. If there's Crohn's, if there are severe adhesions to the pelvis, you may want, in some patients, if they really insist that this is the operation for them, if there are some slight adhesions, most people would try and dissect them, but sometimes if it's a very, very hostile abdomen, it's quite difficult to do, and most people would opt for the sleeve instead. If there's pathology in the distal stomach that needs repeated endoscopy, then it's not a wise thing to do, because it's very difficult to access the stomach retrogradely. And as well as if you think you need to access the biliary for similar reasons. Complications like any surgery can include things like leaks, and you can get little ulcers, strictures, or perforations here, particularly in smokers. Other complications can include mineral and vitamin deficiency, dumping syndrome, and bowel obstruction. Bowel obstruction, remember internal hernias. So we said in the band, if they're vomiting, think slippage. In the bypass, if they are vomiting, obstructed, think internal hernias. Because if the small bowel gets trapped in an internal hernia and it goes ischemic, then you may have a patient with short bowel syndrome and requiring TPN for life on your hands. So prompt identification is very, very important. This is the one anastomosis gastric bypass. It's the newer of these operations. And as you can see, the pouch is a longer pouch, but there's only one anastomosis here rather than the two that we had with the Roux-en-Y. It's got several names, including mini gastric bypass, single anastomosis gastric bypass. There is some evidence that it may be somewhat stronger in terms of weight loss and type 2 diabetes compared to the Roux-en-Y, but on the other hand, it may also be more malabsorptive, and it all depends on how much bowel you bypass. Some people also worry about reflux of bile into the stomach and the long-term consequences of that. Now, in terms of results, we know that bariatric surgery works, and one of the biggest studies is this study, which is the SOS study, the Swedish obese subjects study, where patients were matched, 2,000 that had no surgery and best medical treatment versus patients that had 3 different types of bariatric operations. The type that was done most was the VBG, similar to the band, but not quite. And this is an operation that has now not been done anymore. So even with with the two operations that are not currently regarded as best practice, they had really very good results in terms of long-term weight loss, not only early weight loss, but weight loss that has been consistent for over 20 years. And you can also notice, what's happening with the medical arm. These aren't patients that have been abandoned. Yeah, these are patients that have been in the study and have been still, and it's a great onus to their medical doctors that patients that were morbidly obese to start off with didn't gain weight, actually lost some weight after 20 years. So that's something that we hardly ever see in this country, unfortunately. So the SOS study, looking into more detail, they also showed increased type 2 diabetes remission rates, a decrease in the incidence of new onset diabetes, a decrease in ischemic heart disease and strokes, and decrease in cancer in women. Again, long-term mortality was decreased, early mortality was decreased. And this is comparing the three different operations that we had to lifestyle and liraglutide and lifestyle. So with our three operations, we've got good results with most patients achieving that 10% weight loss. With lifestyle interventions, only about less than 10% of patients would usually achieve that 10% weight loss, while with liraglutide and lifestyle, at least short term, about 33% would achieve that 10% weight loss, but at the cost of having the liraglutide for the rest of their life. So bariatric, this is another overview. So again, it not only helps in terms of weight reduction, but also with resolution and improvement of comorbidities like type 2 diabetes, hypertension, NASH, pulmonary function, obstructive sleep apnea, musculoskeletal problems. It improves quality of life, and it prevents type 2 diabetes, strokes, and ischemic heart disease. And bariatric surgery is safe. Now, any patient that is operated on in the UK needs to be entered in a special database called the NVSR, and the in-hospital mortality rate in the NVSR is 0.07%. That is much less than a total hip, a total knee, and is as much as a lap chole. So that's to put it into perspective what that figure is. So in terms of aftercare, the aftercare starts actually in the preoperative period. These patients, those suffering from obesity, also have a very high risk of deficiencies, especially of vitamin D. It can be up to 90%, but also in terms of vitamin B12, iron, and folate. So the patients need to be screened, not only screened and the supplements replaced, but they also need to be investigated, because if, say, you've got vitamin B12 deficiency, it may be that they've got pernicious anemia. It may be, if you've got an iron deficiency anemia, it may be that you've got a polyps or a asymptomatic gastric or colonic cancer. So it's not just replacing, but also investigating. And this needs to be pre-op. You don't want to be in a position that you're playing catch-up post-op, because the patients are eating less, they may or may not be malabsorbing the nutrients a bit, if it's a bypass or a one anastomosis gastric bypass. So you don't want to be playing catch-up. So they need to be fine from the word go before the operation. BOMS is the Bariatric and Metabolic Surgical Society, advocates that these bloods are checked pre-op, as well as 3, 6, and 12 months post-op, and yearly thereafter. So as we said, the patients are usually within the context of a bariatric center for 2 years. Then they need to be able to get their GPs, and for the GPs to be well informed that they need these blood tests, for the rest of their life. Early in the post-operative period, most centers advocate dietary modification, i.e., immediately after the op, they start on a liquid diet, then onto a very soft diet, initially sort of yogurt consistency, then a meshed consistency, and then after about 4 to 6 weeks, they are weaned onto solids. And initially, it's very common that they can eat a couple of spoonfuls, yeah, of when they're weaned, they're onto a small, very small quantity of a normal diet. This is the typical post-op regimen for a sleeve or a bypass in my center. So they would have a multivitamin, calcium, iron, and B12 every 3 months. The B12 are usually given as injections because obviously you've got less of the stomach, less of the intrinsic factor to have absorption in the small bowel. Now, just one note. This is the APPG, All Party Parliamentary Group Obesity Inquiry. Patients suffering from obesity and morbid obesity tend to be stigmatized, criticized, abused. You can see the current sometimes you get it on the papers when our prime minister announces some new intervention or some new, the photographs that are associated with these snippets of information, and when you are seeing a patient, being it in bariatrics, be it in a orthopedic clinic, just yes, discuss the problem, but do it in a sensitive way, not in a stigmatizing or in a criticizing way, saying yeah, they go and lose weight. Sometimes I get letters from my orthopedic colleagues. The patient needs to lose weight, and I don't know how much before I can do an operation sort of for them. I don't know how much they weigh. They haven't weighed them. They haven't given them a target weight loss. So, I mean, how, if a professional can't see what you want them to do, how can a patient? So please, please, please treat them sensitively. And, there are ways and means that we can help them and get them better. So in conclusion, obesity is a chronic, complex disease requiring multidisciplinary management. Bariatric and metabolic surgery is the standard of care for patients suffering from morbid obesity and its related diseases. Such surgery is associated with increased longevity and improved quality of life. We need to prepare the patients carefully, particularly the first choice of operation is very important, and long-term follow-up is also key. Thank you so much.
Thank you very much, Cynthia, for an excellent presentation. I've taken the liberty to answer about 7 questions on your behalf because of lack of time. Thank you everyone for participating in today's webinar. The next one is on Thursday on varicose vein disease, and I hope you will be able to join us at that time. Thank you. Thanks.